All right. Thank you all for joining us today. My name is Stephanie Doback, and I'll be the moderator for today's webinar titled Comprehensive Team Collaboration in Addressing Nutrition in People with ALS, the Role of the SLP and OT. I'm excited to introduce our speakers, Dr. Emily Plowman and Sherry Kojajek. Dr. Emily Plowman established and directs the Aerodigestive Research Core Laboratory at The Ohio State University. She is an internationally recognized expert in the field of dysphagia who has held uninterrupted funding from the NIH since commencing her academic career in 2009. Her current research is supported by the National Institute of Aging, National Institute of Nursing Research, National Institute of Cancer, and Department of Defense. Dr. Plowman has authored over 85 peer-reviewed scientific manuscripts, given over 600 lectures worldwide, and obtained over 30 external research grants. In addition to her own research, Dr. Plowman is passionate about mentoring the future generation of clinician scientists, and her mentorship efforts were recognized recently by the NIH with the National Institute of Neurological Disorders and Stroke awarded the Story Landis Award for Outstanding Mentorship by a Neuroscientist in 2022, and the University of Florida Doctoral Mentor of the Year Award in 2021. She was inducted into the American Speech and Hearing Association as a fellow in 2022 and was elected to be the incoming president of the International Dysphagia Research Society for 2026. Sherry Kojajek is the director of the ALS clinic at Crestwood Medical Center in Huntsville, Alabama. She has served in this role for over 10 years and has held the charge to achieving the National ALS Association recognition for Treatment Center of Excellence. To achieve this recognition, the clinic must not only provide a multidisciplinary approach to the management of ALS, but must also be active in research. As the clinical research coordinator, Sherry is in collaboration with the Hudson Alpha Institute of Biotechnology on a biomarker study and concluded a study titled Impacting ALS, which sequenced DNA exploring a cause of ALS. In collaboration with Georgetown University and Johns Hopkins, Sherry will be engaged in conducting research on palliative care, outcome measures, and guidelines for management of the complex patient. Sherry is also an active volunteer and serves on the executive board of the Accreditation Council for Occupational Therapy Education and the American Occupational Therapy Association. She completes accreditation review for colleges across the country. She also serves on the National ALS Care Services Board and recently completed terms on the National AARP Driver Safety Board, Executive AARP State of Alabama Board, and the Alabama chapter of the ALS Association Board. She is an invited speaker across the country on topics including Medicare rights, Right to Try Act, Care Service Act, and operations of the complex ALS clinic. Sherry graduated from Boston University with her master's degree in occupational therapy, and she resides in Huntsville, Alabama with her husband, Jeff. So just some housekeeping, we will have a Q&A session at the end of the presentation. You can submit questions via the chat feature at any time during the presentation, and we will relay them to the speakers during Q&A time. Alternatively, you can raise your hand, Zoom hand, during Q&A time, and we will call on you to unmute yourself to ask your question. And at the end of the session, I will place a link to a 4-question evaluation in the chat box. And we ask that you please complete the evaluation so that we can have feedback to continually improve our educational offerings. And lastly, we want to thank the ALS Association for providing the Quality of Care Program Grant to support this presentation. And with that, I will hand it over to Dr. Plowman and Sherry.
Great. Thank you, Stephanie. Everyone can hear me okay? Great. So it's an honor to speak with my colleague Sherry today to you guys, and just let's just make sure I can. Okay, great. Sorry, just getting organized. So just some mandatory with I am an employee and receive a salary from OSU, some board memberships, and some funding mechanisms. So a brief overview of where Sherry and I will take you today. I'll kick things off and start with just sort of a basic physiologic underpinnings of in people with ALS or PALS, what contributes or what's the etiology of the development of feeding, swallowing, and nutritional impairments. I'll then overview conceptually sort of the historical approach versus a more proactive model of care that myself and Sherry are passionate about, and that I'll kind of sprinkle in there some new highlights of some new emerging data that are coming out for some promising therapeutics in this area. I'll end with some highlights from the SLP perspective and hand things over to Sherry, who will then offer the occupational therapy perspective. And then she has some excellent slides that include clinical resources, devices, and equipment that you can hopefully take into your everyday practice. So I do want to just give a quick shout out. Really the PALs are an inspiration to me and sort of help me get out of bed and want to do what I do every day. So I just wanted to briefly start this talk, and these are sort of a picture montage of some amazing humans that I've had the great pleasure and fortune to work with in my career. So just briefly, I know this is a bit of a review for everyone on this call, but ALS really is an interesting constellation of neurologic symptoms, and it's the only disease, in fact, of course, that includes a constellation of both upper and lower motor neuron impairments. And depending on where the disease starts, overall, the upper motor neuron impairments will lead to muscle stiffness and slowness, decreased range. Low motor neuron impairments, as we know, lead to decreased muscle force and speed. And this constellation of symptoms is important as it really sets the framework for what we see with an evolution of feeding and impairments that then, of course, lead to malnutrition in individuals with ALS. And when we review the published King's staging system for ALS, you'll recall that there are 6 different phases. And what always strikes me as being really important for what we all collectively do is that the stage preceding death includes respiratory and or nutritional failure. And so what we do, I think, is really, really important to potentially not only maintain function, but to try and prolong this for as long as possible. So just very briefly to sort of set the stage here, this is the gold standard swallowing test called the Modified Barium Swallow Study. And unless one has X-ray vision, this is needed to determine somebody's swallowing function. And this is a classic individual with ALS who you can see is having great difficulties with propelling this bolus from the oral cavity down into the esophagus. And so we would classify this as an efficiency issue where you can see residue in these natural pockets in the throat. So this is a lot of what we call vallecular residue resulting from impairments and weakness progressively of the tongue. And we know that this can lead to malnutrition. People actually start to consume less, or they start to take longer and expend much more energy and calories to get the same amount down. Additionally, we know that PALs have aspiration and safety impairments, and I'll just slow this down and pull it back, but you can see, hopefully appreciate here, material going into the airway. And we've characterized this in many studies in my lab. And unfortunately, many of these patients have an ineffective cough response to expel the tracheal aspirate, which becomes quite important in their management. So I'll just play this through and you can kind of listen to the cough response. Whoops. And from a dietary standpoint, and for the dietitian, it is really important to work closely with your speech language pathologist to ensure what are they actually capable of safely consuming and efficiently consuming. Because if it does take them, a very long period of time to get a meal down, that's where we come together nicely with the review together of the instrumental imaging that I've just shown here. And so I know I'm preaching to the choir here, but consequences of swallowing impairment can include social isolation, fear, and reductions of mental health. I always like people to imagine, sitting at Thanksgiving dinner and having to, even for some of my younger clients, sort of have a spit bucket and having to expel their saliva into a spit bucket, and how isolating, that might be, or for a birthday or a celebration to not be able to participate in that really does affect one's mental health. Of course, compromised pulmonary status with the airway safety issues, development of pneumonia, development of malnutrition, which is really important to this group, and eventually death. And so one thing, that really intrigues me in this specific patient population, and I term this the perfect storm, is that they're really at such a high risk for malnutrition. And we know that evidence shows that this exacerbates the progression by about eightfold. The two things are obviously falling, and if they develop malnutrition, to exacerbate the disease cycle. And as we all know, PALs are in a hypermetabolic state, so they have a need to intake more calories than you or I. But at the same time, as you can appreciate from the video fluoroscopy images, they're getting in decreased oral intake. And that could be because of their dysphagia. It could, of course, be their hand to mouth impairment of being able to feed themselves. In some patients, they have depression and they're obviously not as hungry as maybe they were before. And so this becomes very problematic if one's not taking a very proactive, sort of ahead of the curve approach for them to become malnourished. Just a resource for anyone that is interested. I took a screenshot of this morning, and I was shocked to see that actually this has now had about 33,000 views, but this was a blog and an interview I did for Dysphagia Cafe. You can go to dysphasiacafe.com, and if you go to the search function and type in ALS, this should come up. And for those of you that want to kind of read more about this and the SLP's role with the dietitian, I'd kind of orientate you to that in the interest of time today. But when we review the historical management approach in general for ALS, this is lifted from a screenshot from the American Academy of Neurology. It's very reactive in nature. So for example, you'll see here that mechanical insufflation, exsufflation, or cough assist therapy is typically prescribed until peak cough flow is less than 270 liters per minute, which is well below normative sort of standards. So it's sort of this wait and see. Hopefully we can detect it in a timely manner, and then we apply the cough assist. And similarly, non-invasive ventilation when FVC drops below 50% predicted. And typically there are these compensatory approaches to aim to conserve energy, reduce pain, and maximize quality of life that are shown here. And so this is a very disease-centric reactive approach whereby the disease dictates the treatment decisions and the timing. And this places the patient at the mercy of unknown disease course, the emergence of impairment, as well as access to clinics and a clinician's skill to detect impairment. And with swallowing, since we don't have X-ray vision, sometimes, that can be misaligned and it's not caught early. And, in my lab and in many other centers around the country, we've really looked at this disease-centric reactive approach and thought about, we know in this population that there'll be an eminent development of cough impairment, swallowing impairment, and respiratory impairment. And this doesn't take an advantage of a potential early potential to improve, for example, physiologic reserve to extend oral intake, participation, function, and quality of life. And so just some resources for those that are interested. A review article that was published some time ago looking at different proactive approaches that are in speech language pathology type journals, but I would refer you to those if you're interested in this. And so this historical reactive approach, we've really pushed for a more proactive approach whereby there is a personalized and rather than disease-centered model, it's a patient-centric model. And this can include behavioral, pharmacological, as well as assistive technology and devices that Sherry and myself will overview today. So I like to call it staying ahead of the curve and not waiting until, there is an issue. And a proactive approach can really aim to increase and maintain physiologic reserve for breathing, airway clearance, and oral intake, maximize quality of life into progression, actively engage the patient in a disease management process, which I think is extremely empowering and important. Empower and enable the patient and their family to take ownership of the disease course and management decisions rather than the opposite. And so sort of our proactive model of care that we are really passionate about flips this model And rather than the disease sort of defining treatment decisions, the patient and family members are educated with our best and current data and evidence base, and then they're in a proactive manner informed and given the option to take charge. And so what would elements of a proactive care program include? And I would sort of posit, and this is not by any chance the Holy Grail, but just in my opinion, that it would include prediction elements of who may develop in my line of work, a swallowing impairment, prevention aspects, detection and treatment. And so we want to have prediction models for early identification of the highest risk patients for personalized triage care, because the beautiful imaging I showed you earlier, we don't have the ability to do that on every patient in an ALS clinic. Prevention will help health and clinical practice guidelines to reduce any modifiable contributing risk factors. Early detection with sensitive screening tools and assessments will allow timely and cost-efficient diagnostics. And finally, implementation of personalized and mechanistically targeted interventions will be most helpful to prolong these vital functions. And so I'm going to just highlight, and sort of in the interest of time, just give you a little bit of a sprinkling of what some of these could be, and hopefully give you some tips and tricks that you can apply in your own clinical practice. And the first one I'd like to start with is detection. And at my former institution, I worked in a multidisciplinary ALS clinic. We would see about 20 patients, up to 20 patients in a day. And similar to, I'm sure, all of you guys on the call here, we would get about 15 minutes with each patient. And as a speech language pathologist, we were charged with communication and swallowing, and work that I researched that I have done really was organically sort of informed from my experiences and frustrations in wanting to best serve the patients and their family members, but wondering, well, what clinical tools or screens would give me the best bang for my buck in like a 10-minute period? Because of course, we're also dealing with psychosocial issues that we want to be sensitive to, and we don't want to rush the patient. And so some of this work was born out of this. And so I just wanted to highlight, to begin with, a validated patient report outcome. You may have heard about this. It's called the Eating Assessment Tool 10, and the EAT 10. And this is where patients rate their level of perceived swallowing impairment on a 5-point ordinal scale. 0 would indicate they feel they have no problems at all in this area, whilst 4 would indicate a severe problem. There's 10 items with a total score of 0 to 40 that would indicate normal to severe impairment, respectively. And the nice thing is that this is free for download. This is a link here on the Nestle site download. It's been validated actually in over 10 languages at this point in time. So it is very accessible for any of your patient populations. It is quick to administer and score. In many settings, you can have a patient pre-fill this out online before they come in, or in the waiting room, or if they're in a multidisciplinary clinic and waiting in between visits. And then a clinician can compare the score against published criterion for their likelihood of having dysphagia or being an aspirator. And so in my lab, we've recently published 2 different papers that I'll just quickly highlight just as a reference. And the first is this one published by my postdoc, Dr. Kara Donahue. She's now at Vanderbilt. But just to kind of show you here that, again, to remind you, an EAT 10 score of 0 would indicate that the patient perceived they had no swallowing problems at all. A 40 would indicate extremely severe swallowing impairments. And along this x-axis along here is a rating scale, and we don't have to worry too much about that, but just to know, a 0 would indicate that instrumentally confirmed completely normal swallowing. A 1 would be mild dysphagia, a 2 would be moderate dysphagia, a 3 would be severe dysphagia, and a 4 is considered life-threatening dysphagia. And so that's why there's only 1 there. But you can see really nicely here that there's this dose response sort of curve here for patients reporting higher EAT 10 scores as it tracks with actual dysphagia. And I won't go into the weeds here too much, but basically this had a, when we looked at what is the relative sensitivity and specificity to detect dysphagia, the area under the curve was 0.83, so meaning it had about an 83% sort of accuracy of correctly classifying if a patient was dysphasic or not. And then just briefly, the second study that I'll highlight is one where we looked at patients' aspiration status. And you can see here the aspirators on average had a score of 20 compared to about a score of 4 for the safe swallowers. And when we looked at non-aspirators versus aspirators, using a cut point of 8 or higher, correctly classified about 86% of aspirators. And so this was very useful clinical data, and at many of the places I've worked with, neurologists would use this. And if they scored an 8 or higher, they would refer to a speech language pathologist for further evaluation. And so this sort of led me to do a study, and this is currently unpublished data, but excited to sort of preview it here. It's under review for publication, but we sought to develop a valid and sensitive clinical screening tool that really anyone could utilize, that would inform clinicians of a patient's relative risk for dysphagia. And we felt it would need to have multiple pragmatic screening tools. And just briefly, the final model that we came out with has an area under the curve of 0.93, meaning that for every 100 patients that would walk through the door, that 90, it would correctly classify dysphagia status in 93 out of 100. In the interest of time, I'm just going to quickly go through this, but essentially a patient would get a PRISM value, that's the name of the screening tool. And for example, if they got a score of 8, it would mean they had a 20 times higher likelihood of dysphagia, which is pretty powerful. We're in the process of, this is the prototype, developing this into an iPhone app and a website so that a clinician, it has the EAT-10 that I just previewed, can slide the scale along. It also includes maximum lingual pressure, peak cough flow, and their ALS onset type. So a clinician would sort of go in and check these off. So just briefly, and then I want to hand it over to Sherry to give her enough time. This is also some recent unpublished data looking at the benefit of feeding tube placement, and this is so we compared survival in individuals who underwent a feeding tube placement versus those who didn't. And the overall results showed a positive survival advantage in individuals who did elect to undergo feeding tube placement. And I will whiz through this quickly because I know I want to give Sherry enough time. But essentially, the risk of death in individuals with ALS who had a feeding tube, this number down here, this shows, because it's less than 1, that it was protective, and essentially feeding tube placement represented a 14% decrease in the risk of death in individuals undergoing a feeding tube placement. So just some sort of data to highlight there. And then I believe this is my last slide here. So looks like I'm doing pretty good on time to give Sherry enough time, but we have recently published a study with looking at the pharmacologic potential benefit of a drug called Nudexta, which is FDA approved in ALS. And we noted that in individuals, this was a pilot study funded by the ALS Association, so we're appreciative of that. But essentially, there was a significant increase pre versus post 30-day of Nudexta in their ALS functional rating scale bulbar score. We also saw an improvement in their instrumentally confirmed dysphagia status. And interestingly, we also found some of the secondary speech acoustic data that there was an improvement in the speed of their speech, which, as you know, can be impaired in individuals with ALS. And then sorry, I lied. I have one more slide. And although it's not directly related to the topic today, I really did want to put this in there as well because it fits beautifully with this proactive model, and airway clearance capacity is indirectly quite important for nutritional intake because we do have to work together to make sure our patients have safe swallowing and can protect their airways. But we've done a series of studies highlighted here to show that there's an improvement in individuals who proactively undergo inspiratory and expiratory muscle strength training, with the latest study published in Neurology, and it's featured in one of their podcasts. But essentially, in individuals randomized to the active respiratory strength training program, they had a 12-month delay in time to non-invasive ventilation, which we were very happy about. So there are some resources here on, it's actually my old laboratory website, but it's still available for patients as well as clinicians, that are free for download, and includes a lot of the papers that I highlighted here. So I will stop my share and hand it over to Sherry. Thank you.
Thanks, Emily. And we'll come back for question and answers for everybody. I'm going to pull up Sherry's slides for her.
So she's helping me out because where I'm at, they are upgrading the system, which has resulted in a lot of hiccups. And I've been speaking for the last few days, and it's been something. So can I take it from there? Slides going. So she's going to run my slide. You guys will just hear me say advanced. Next slide. I want you to know from this slide why this picture is here. Is there's a bridge you can see further back. And oftentimes, every time I should say, when I do the pre-intake interview with my clients, it's what do they want to achieve? You know, what are their goal? And this was the picture that one brought in. I want to be, as long as I can be able to hike, wheel, swing, whatever it takes to get me around this area, which is really important to my part of the talk. So next slide. So the disclosures, I really don't have any for this talk, but I do work at Crestwood where I receive a salary. And of course, we're about to do the palliative care study where we did receive the quality of care grant from ALSA to work on that, John Hopkins, Brown and I. Next slide. So we're really going to touch onto that. Emily's is just really a nice segue. It's like always amazing to me working in this field of how we're cut from the same cloth, right? Because we're all wanting the same things. But we're going to go really what the OT's doing, as well as, you know, the importance of the collaboration with both of us, and some interventions that are important. So next slide. So this is going to set the stage. You can see me there, and then you can see in the middle Rick. And this was at a stage in Rick's journey with ALS where days before we had talked about next steps. The next steps for Rick getting a feeding tube really was still a bit away, but as Emily even pointed out, the more you can be proactive and plan for 3 months from now, 6 months from now, the better quality of life your patient really will have. And so if you look at this picture, you think, oh, it's Rick, we're going to get him a feeding tube, but it's knowing the facts around Rick. What's most meaningful to Rick in the picture is his dog, Mango. His concern with the feeding tube was Mango. This dog sheds like crazy, little bitty sheds, and Rick preferred not to have many clothing items on him at night, but Mango slept next to him. You know, so knowing that information was important. The other thing you can't tell from this picture is Rick is limb onset. He does not have the ability to do a bolus. There's no way he can operate any of the ways to get a peg tube feeding in, nor feed himself. So then that leads you to look at the caregiver, whether it's the wife or the neighbor coming in or the cousin, who's going to be the one doing that, and what are they capable of doing? And that's what we miss sometimes, right, in clinics, is we make recommendations, they're not successful for the patient, and they get frustrated. So that's what I want you to keep in mind is, had we just thought, well, you know, breathing is going down, he's losing a considerable amount of weight, he can't swallow anymore, we're going to put a peg tube and we're going to recommend this type of formula or this type of entryway without knowing the rest of the story, it can really set up someone for failure, which we never want. Next slide. So this I want to include, you all know what you do, but this was some snippets from a survey we did years ago through NEALS. We are a NEALS research site here at Crestwood. And really we're curious what the team thought you all did. And there were things I left off that were interesting. but there were things that were spot on, and these were there that got checked off the most. The interesting part is they didn't know why. So they knew you probably conducted a thorough nutritional assessment, but they didn't know how you did that, right? They knew you adapted consistency of foods and liquids and collaborated with your speech, but they didn't know how, and they didn't know why. A lot of them felt that you really did spend time talking about what we see a lot in this population, vitamins and the supplements that they may also introduce. And then the last one about alternative forms of nutrition, about tube feeding, they really thought you were a big part of that. So that was great, right? What was interesting was going back up to how and why. And so at our clinic, and in the clinics I worked at previously, we have quarterly in-services where each team member is teaching the other one what they do. Each team member tries a cough assist. Each team member tries different consistency of foods, because it's one thing to go in that room and discuss it. It's another thing to be able to say, yeah, I tried it in one of the in-services, here's how it tasted, kind of thing. So it's really important to be aware of what I'll be pushing a lot today, which is team collaboration and really making sure each team member understands what the other one does and how it may impact the care plan. So next slide. And this is a little bit about what occupational therapists do. So, our training, as you all know, is in those areas of self-care, work, leisure, play. IADLs is everything from working to driving to going to school. Either the OT or PT in the clinics are going to be doing that power wheelchair eval, which is really important for you all to know, because if you've decided you're going to do a gravity bag, then we need somewhere to hang that gravity bag, right? And that's an easy addition to that chair. We recommend and train in the use of the assistive devices, and I'll show you some in a little bit. And then we are assessing the ability to visually, cognitively, physically manage the PEG tube and any other equipment in collaboration with our team. So that's a good thing to go back to. So in our clinic, we have, so I run the clinic, and I do a pre-Zoom meeting before every clinic visit, where the team gets together. I've already done all the intake interviews. Our patients all get mailed a package to email me back or bring with them. So the ALS functional rating scale's in there, a fatigue scale's in there, but a 2-day food recall for y'all is also in there, right? So we have a little better picture in the last 2 days or any 2 days, what are you actually getting in? It's everything, snacks, the whole shebang. So we'll get that information, have that collaborative meeting. So when that, as Emily pointed out, some clinics, the therapists are getting in there for 15 minutes. So they're going in as efficiently as possible. I'm giving in that call some of the other stuff we're going to go over in a little bit, which is the things that may impact your recommendation. So next slide. Are we going backwards, or did that pop up twice? So we'll go on this one. I think I've got this in there twice, but anyway. So the team is extremely important. I cannot stress it enough. Our outcomes at Crestwood, this was a challenge for me. This is the smallest place I've ever worked. And the challenge was, could it happen? And could it happen and I achieve the Center of Excellence, which has been going on for 15 years now? Because it can, because we collaborate so strongly. Because I pull the team over from the inpatient side to my outpatient clinic on day of clinic. But they're all here. These patients are here about 4 hours, and they're seeing 8 specialties. Plus our vendors in the community are here as well. But the team collaboration is so important. But other things I want you to think about, and we'll talk about this as we go through the talk, is how does the health of the caregiver affect your recommendations? So just be thinking of that. What if the insurance doesn't cover the enteral? So if you're one, I'm in Alabama, the Blue Cross of Alabama, it's $150 a month for your Jevity and your 2Cal, and it's $240 a month for your products like Kate Farms, right? That's cost prohibitive to a lot of folks. So if we go in the room and we're recommending an enteral, but then we find out in the back door that they can't afford to get it, I get a lot of calls, right? Not from my clinic, of course, but from around that. How do we get this? Because I'm not able to get it or I can't afford it. So it's important to know that. When Emily mentioned about some of the equipment like the cough assist, there's folks that don't realize that if they're going to be using that peg, that's really important to burp it before you're doing your cough assist, or you're going to get a very distended belly. So who on the team's going to tackle that in terms of teaching the patient as well as the caregiver? Can your patient and their caregiver use their hands? Do they have the sustained strength to be able to push something through a syringe? Do they have the vision to even do that? And working with your speech pathologist, do they have the cognitive skill to follow the directions to do too many steps? So prior to making your recommendations, it's really important to know all those facts that may affect the delivery of either the food or what I really want to talk to you guys about as an OT, the PEG 2 recommendations. And again, that goes back to that first point. That's the real importance of having team collaboration. Again, I do a Zoom call prior to the conference or the clinic. And then I do it when the team members arrive, and then it's done live as need be as a clinic director when something changes. And then we wrap up near the end as a quick where we think we're going. Okay, next slide. So feeding and assisted devices, this is coming back to the OT. There's a Rick again. Again, you can't really tell in the picture that he's a limb onset. He had a little bit of movement in that right arm, but really the left arm was non-functional. But all the things I'm going to show you some pictures that you should have in your toolbox, especially the OT, but the team should have full access to it, or anything to keep Rick successful. And he used it all. He went from thick handled utensils. They got too heavy. We went to built up foam, couldn't hold on to that anymore. We went to a universal cup where the spoon can slide right in that. Just have to have enough movement in your wrist. Long straws when he wanted to be able to bring that liquid up, but couldn't really bend forward, or his wife was a tad busy. Plate guards, which I'll show you, all sorts of things, but it's constantly adapting from a standpoint in ALS clinic, and it's constantly doing environmental analysis. So, and we'll talk about that more later, but basically, the mistake that gets made sometimes is, oh, Rick can't hold that utensil, we'll put some foam on it. But can he do that at the restaurant? Can he do that at home? Even if you give him some of these devices, is he able to get that hand to his mouth? And if not, how are you going to do that? And we'll talk about that, and we'll talk about the PEG and the feeding tube adaptions in just a minute. Next slide. So some of the things you may hear about or see in the clinic are robots that are out there. They're lovely. We definitely have these we have labs here at my clinic where people can come in anytime in between clinics and play with things. So this is the OB robot. It does require calibration to make sure it's getting the food where it needs to go to the patient right. There are, from my field, OTs that'll go in and recommend it and come back to me and say, we really want to get them one. And that's nice, but these things can cost $8,000 to $20,000. Some insurance can cover it. I've been able to get it through some. I've been able to get it through Medicaid a few times as well. If it's a veteran, it's covered for them. But it's a device that if they do not have the ability, and Rick actually used one of these as a trial for the company to see if it was successful for him, and he could. We worked on voice activation for him and then on eye gaze activation eventually, but he was able to do that as long as he could safely swallow and eat. Next slide. And this is the I Eat feeding robot. So it's same with the OB. There can be coverage. I always advise my team to make sure, if you're thinking about it, before you talk to the client, talk to me first, right? Because we want it to be successful for them and not feel defeated that, oh, I got excited about a device and then it got taken away from me. Why I included this picture is all the pieces to be aware of, right? So this is a guy that required the environmental adaptation because he could not access this device at his house because he did not have a table to get his wheelchair up to be able to do it. A bedside table didn't even work for him. The other thing, looking at his pictures, you can see where his finger is on that button that activates this device. So if your patient doesn't have the strength to do that, doesn't have the mobility in that shoulder to do that, this is a failure for them. and people get lost, especially some of my residents that float through. Yes, but it's a robot and it's going to feed him for it. Well, it will as long as he can activate it. And he was successful, but we had to move that switch up near his shoulder, and then we had to unload his shoulder, meaning we had built up a table where his shoulder was rested, so he could get that button pushed as he needed to activate that device. That is something really, something you all feel that, that you feel they're safe. You talk to your speech path, your decisions, they're still safe to eat, it's something to really talk to your OT about when, they may not have the mobility to get hand to mouth is what can we do? What can we afford to do? And then that clinic director who should know all that stuff. Okay, next slide. And so this is some of the adaptive feeding kit. Actually, some of the ALS chapters will take some into the homes and be able to show folks, and not only show folks, but give them some of these devices. We don't encourage that a lot at our clinic because oftentimes it's too early, and that just sets up some depression as, oh my gosh, I'm going to lose the use of my hands later, or they're just not going to be successful with that device, right? That gray handled spoon you see in that is a lovely idea, but it's heavy, right? It's definitely heavy. You can see the blue is Dicem. That's just sticky stuff to keep the plate from sliding around. There's a pill crusher in there. You can see the cups that Emily referred to earlier, the nose cutout cup. There's a sippy cup. And then the plates, one's a scooped cup and the other one's got a plate card. So they still have the mobility to feed themselves, but not the strength to keep the peas from flying off the plate. That's what those are all about. So again, this is a journey you're on with these folks, but it's not just in that clinic when you see them. You may not see them for 3 months. Things are going to get worse. So plan ahead. I'd rather in this clinic they have it at home and don't need it than want it and I've got to get it to them. Again, in our clinic, I run my own loan closet. It is, goodness, half the size of a football field, and all this is in there for them to try, and they can come and get it at any time. But good stuff to have. I should say with all of these devices, not only is it really important they get to play and try with them, but we do have labs set up where they can go around and just what's best for you. We have a very mixed culture here. So there are some items that are more acceptable to be used. There are actually some ways that a person's fed that are more acceptable than others. I have one family now that even though when we did the caregiver assessment, the wife was the best to do that, it was not accepted in their culture. The oldest son was the one that needed to be feeding dad. So it's really important to evaluate those things. And it goes in line with these devices, what they're willing to do. A family that's, luckily I got them everything free, but their resistance was in their culture. The parents do not spend money on themselves that should be safe for their children. So it's been a journey to get them to accept certain devices that needed to be purchased because it's just not accepted in their culture. Okay, next slide. So this is where, I liked what Emily talked about, that collaboration with speech. So in our clinic, what we see a lot, and this is my 18th clinic, is you all really collaborate strongly with the whole team. I mean, you're one of the strongest backbone, of course. So I think speech is, I think RT is, but in the beginning, it's more with the speech pathologist, right? Because we rely heavily on you, the people that are running the clinic, the physician, that you all came up with the best consistency, the best liquid. How is that going to go down that we are actually achieving a nutritional benefit for the patient, right? Because you all hear it if you haven't already, I want to eat forever, but it's so slow and tiring. They're just whittling away to nothing, or wounds are not healing because they're not getting the nutrition that they need. What we see the shift start happening in terms of collaboration is when it comes to the peg is going to be placed. Then you see that collaboration with a dietitian being more with the occupational therapist, right? Just like what we've gone back to before is, okay, I think we're ready to do this. They're accepting it. Again, I as a director, I'm always talking about these things, being proactive. I always know which way they want to run. We have a heavy Mickey tube adoption here, and I'll show you a picture of that later. But I can come to the dietitian as a clinic director and already plant that seed. This is the way they're going. The caregiver's got severe rheumatoid arthritis. There's no way they're going to handle the syringe, or they travel every weekend. They need a quick way to be able to do management of this formula. So collaboration's key. Some of the things we look at, you see there is the caregiver and what they can do. What's their typical daily home schedule? I happen to have a lot of 30-year-old males in my clinic. My youngest is, goodness, he's 15 now, started him at 7. So what's the typical daily home schedule? Are there kids? These parents need to get out of school. What's the best time they're going to do these feedings? Is gravity bag more important because that's 20 minutes? Or does she have that 4 to 5 minutes plus prep to get ready to do a tube feeding? It's really understanding all of that information. And that's part of the pre-assessment that we do. What medications are they on? Can they all go down the peg? Do they need to be crushed? Are there ones that can't go down there? And your positioning that you all know is, can that person remain upright? I mean, we see that sometimes where the best time in the day for the family to feed him is at night, while the kids are in the bath, or they're trying to get dinner, but the person they've already put to bed and they can't get them upright enough. And then they have a nighttime of stomach upset. So all that comes into play when you're thinking about how you want to recommend the entryway. Next slide. The other thing that we see a lot, and this picture, you can actually get a pretty easy grant for, which I can share later. We pass these out as we need to in our clinic. But what we see a lot, especially with our elderly caregivers, is they can't even open these cartons. So they get them there and they're calling me, the worst, if you guys know, that happens is the cartons that weigh, if you've never lifted one of those cartons, they're not light. The whole case for the month is not light, and the UPS driver will leave them by the mailbox, and the elderly caregiver's got to walk downstairs through the bad weather to try to get their box. So there's ways to work around that. This is another way to work around when I can't get it open. So that's something at clinic, either the dietitian, the OT, we're looking at this at clinic. This is what the carton looks like. We have them here. I'm leaving the room, you guys play with, open it. Most of our samples are just empty samples so they can play with the different cartons. So we assess before they leave what's going to be the best way for them to be able to feed their loved one, right? Because again, last thing you want to do is set up for failure. But this is a nice little kit. This is the sticky dice in the red circle, and then just a couple of other ways to pop it open. Next slide. This is one of my favorites. This is it's a Boink connector. So this is, say you've recommended a gravity bag, and you guys have seen that. It's the bag, you can hang it from an IV pole that's usually covered by insurance. I get patients sending me pictures where they're traveling down the road and it's hanging from the hand pole in the van going down the road. But there are some patients that are less mobile now, but they really don't need or want a gravity bag. They can still manage to get their feeding tube, their feedings done themselves. So this is a nice alternative for that, because that little connection, this goes right to the top of the carton, and then the rest goes right into where the feeding tube is. A lot of my folks that travel extensively love these things. It just easy and quick, right? They still have to get that carton gravity protected so that drains, right? And a particular patient that he's on his way to Pebble Beach now, they're going to do Velcro. So he Velcros to his wheelchair. So it's up there enough and he can manage it himself, which is incredible, right? That's where the OT passion is how functionally independent can we keep you for as long as we can. So this caregiver doesn't get disheveled and we lose that, right? So anyway, great little device. I'm constantly calling that company, getting free samples. So I stay pretty well stocked and I can give them away for free. Next slide. So this is your Mickey tube, and you all know this, I'm speaking to the choir, so that peg tube usually goes in on average in most clinics around the United States. And in 8 weeks, they can go ahead and have it changed to a Mickey tube if that's the care plan. I can tell you in Alabama, I have very few that will do that. On average, and other states having the same issues, they just feel adults shouldn't do a Mickey tube. But a lot of them do. A lot of our folks in this area, right where I'm at now, are employed engineers and are trying to stay that way, and they want their Mickey button. And we run into trouble with that balloon that's in there, right? Because if you're less mobile, that thing usually needs to be changed every 3 months once you get that Mickey tube in. And so if your patient's less mobile, that's just not a good recommendation to go if they can't get where they need to go. We're lucky in our area. There is a grant I went after. So we have nurses that go in the home every 3 months and change that out. And we also have a caregiver training lab where the caregivers, because parents for their kids do it all the time. So why can't an adult do it? So we're piling into that to see how that goes again in the area, but so far so good. The other thing that I wanted to point out is they get this placed in order to order them from the vendors. You need to know 2 things. So oftentimes the order sent from clinic to the vendor is the size of that Mickey button. And you can see this one here is a 16 French by 3 centimeters. But they're extenders that connect that to the carton or wherever they're connecting it, but usually a syringe or a carton. Is a different size, and you need to make sure your client is getting those in the home as well. Because oftentimes the vendor will just send the emergency backup Mickey and this Mickey size once every 3 months, but forget we need the extenders as well. While you're looking at it as a dietitian, as an OT, though, is can my client, this is a lot smaller button, right? And the tubing to get this formula in is also smaller. So you really want to make sure the patient and caregiver can manage using these buttons. But again, we're for some reason, we're a high adoption of these here and have no problems because it's your surgeon to be full. And see, what I do is, you know, your balloon shouldn't burst, but they can. So you really want to make sure you got a surgeon that's very comfortable putting them in and is very aware of the placement of putting them in, so we don't have that issue. Next slide. Oh, I'm already there. So I don't know if I went too fast or too slow. But I'll go and then we'll go back. I saw a couple of questions. Well, we can do that. So again, what I want you to remember is team collaboration is key. You know, if you don't do it now, do it and do it and do it again. If you can add a quarterly education session where you or your team members present to each other, that is what's kept us in the forefront, and we get invited to speak a lot. Our outcomes are really, really high here. Our average life expectancy is actually 7 to 10 instead of 2 to 5, but we're very aggressive and proactive. We early adopt our PEG tubes, honestly. We don't wait for 80 because the complications of waiting too long and you just can't tolerate the surgery, or you have too many days of recovery after. So that works well for us. We also invite vendors in our community to come in again, as we mentioned earlier, so they can feel what a cough assist feels like and get to play with the different enteral devices that are out there, respiratory, wheelchairs, everything. The other thing that we really like to do is make sure that client, I know I have it in this area, is it's just ever changing, unfortunately, when people pass, is that we have someone that's actually doing it, and they're always in attendance at clinic. So if a PEG tube feeding is being done, everybody here knows it, and they can step out of their clinic appointment and go work with the caregiver that's doing it, seeing how it's done. Again, it's one thing for us to tell them, but to actually see it being done really puts them at peace a little bit more. Again, we come into play as OTs because we want to look at, can they be successful for everything, but in your world, with whatever you're recommending. So do they have the vision to do it? Is there a way I can get, and they're out there, a high vision syringe where the numbers are bigger? Is their cognition fine? Can I work with speech path and maybe have it broken down a little bit by steps? Do they have the endurance to do it? This hits caregivers a lot. If they're standing up holding a gravity bag, because a lot will do that, and we don't want them doing it. They don't have the endurance or the balance to tolerate it. And then again, evaluating all components of care need prior to recommending that type of a formula, especially if one and going to be a lot of out of pocket, and then how they're going to be able to do it successfully. So that is me in a quick nutshell.
Thank you so much, Emily and Sherry. That was absolutely fantastic. So